Hi, my name is Alicia Marks, and this is an educational video on fluid and electrolyte imbalances for Nursing 110 Medical Surgical Nursing through the University of Charleston. First, I will start by answering a question. So the question is, what 5 different labs will indicate fluid volume deficit? And these are hematocrit, BUN, urine-specific gravity, blood sodium, and blood osmolality. And your hematocrit will be increased with hypovolemia. Your blood urea nitrogen will be increased to a value greater than 25 milligrams per deciliter due to hemoconcentration. Your urine-specific gravity will be increased to 1.030 or above, a number greater than that. Your blood sodium will be increased to a value greater than 145 MEq per liter in cases of dehydration. And your blood osmolality will be increased to a value greater than 295 millismol kilograms, sorry, that's a tongue twister, in cases of dehydration and or hypernatremia. Electrolytes are charged ions dissolved in body fluids, with cations being positively charged and anions being negatively charged. Electrolytes are distributed between intracellular, also known as ICF, and extracellular, also known as ECF, fluid compartments. This distribution of ions differs in the ICF and the ECF. And the purpose of electrolytes is that the difference in the ICF and ECF maintains cell excitability and allows for transmission of nerve impulses. The expected reference range for sodium is 135 to 145 MEq per liter. The expected reference range for potassium is 3.5 to 5 MEq per liter. The expected reference range for calcium is 8.5 to 10.9 MEq per liter. And then I'm going to go over our expected range for chloride, which is 95 to 105 MEq per liter, and phosphorus, which is 2.5 to 4.5 MEq per liter. Now these numbers, I've taken these from a nursing exam cram sheet for NCLEX RN, and these are figures that we use in our program that are approved by our professor, but every institute will have their own reference range. They're still going to be in the same numerical order, like you might have 2.5 or 2.9, or, you know, in this case we had 10.5 or 10.9 for chloride. But it doesn't really matter because you're going to know the difference, because they're not going to give you a 10.9 as you're outside of your reference range. They're going to give you an 11 or an 11.5. That way you know what's going on the NCLEX. All right, so range that this is in. Okay, so the signs and symptoms of hyponatremia are muscle weakness to the point of possible respiratory compromise, confusion, headache, lethargy, fatigue, decreased deep tendon reflexes, seizures, lightheadedness, dizziness, increased gastrointestinal motility, hyperactive bowel sounds, abdominal cramping, and nausea. An easy way to remember the general tenets of hyponatremia is to focus on confusion, muscle cramps, and weakness. So these 3 signs and symptoms encompass a lot of what is going on within the body during hyponatremia. Okay, so hyponatremia can occur due to excess water consumption, and this is referred to as dilutional hyponatremia. An example of this would be a salt to water ratio of 1 to 10. So your patient's going to have very little salt and a whole lot of water. Patients with this type of hyponatremia's main symptom will be diarrhea, which is making sense because you have all this water in your body compared to salt, so it's not binding correctly. Your clinical indicators of hyponatremia are going to depend on whether the ECF volume is normal, also known as euvolemic, decreased, also known as hypovolemic, or increased, also known as hypervolemic. If the client is hypervolemic with hyponatremia, their pulse quality will usually be bounding, with a blood pressure that can be within or above the expected reference range. The client may also experience hypothermia, tachycardia, a rapid thready pulse, hypotension, orthostatic hypotension, and diminished peripheral pulses. Nursing care of hyponatremia includes encouraging foods and fluids high in sodium. This is only the case where the client can tolerate foods and fluids by mouth. Then you're going to want to encourage that sodium intake. And then administration of isotonic IV fluids can help with hyponatremia. Replacement of sodium should not exceed 12 MEq per liter in a 24-hour period because of rapid rise in sodium level, and this risks development of neurologic damage due to demyelinization. In cases of diluted hypernatremia or fluid overload, restrict water intake as prescribed. So monitor the patient's intake and output and daily weight, and monitor the patient's vital signs and their level of consciousness, reporting any abnormal findings to the provider. The main signs and symptoms of hypernatremia are thirst and dry flushed skin. You can also experience hyperthermia, tachycardia, orthostatic hypotension, restlessness, irritability, respiratory compromise, decreased or absent deep tendon reflexes, seizures, coma, dry mucous membranes, nausea, vomiting, anorexia, and occasional diarrhea. Hypernatremia stimulates the antidiuretic hormone, and this leads to water conservation and concentrated urine. Nursing care of hypernatremia includes monitoring the client's level of consciousness and ensuring their safety, and monitoring vital signs and heart rhythm, auscultating lung sounds, and providing oral hygiene and other comfort measures to decrease thirst. Monitoring intake and output and alerting the provider of inadequate urinary output is also important, and if the patient's hypernatremia is due to fluid loss, and this can be determined through blood osmolarity and hemodynamic stability testing, there are some different nursing care actions to implement. So you're going to want to administer hypertonic IV solutions, and be aware that once infused, glucose rapidly metabolizes and becomes a hypotonic solution. So you're going to want to be aware of that, and in cases where the patient, you might want to administer 0.3% sodium chloride, which can be prescribed as a hypotonic solution, which provides a more gradual reduction in blood sodium levels and reduces the risk of cerebral edema. And this is the preferred IV solution if the client also has severe hyperglycemia. With excess sodium hypernatremia, you'll want to encourage water intake and discourage sodium intake to dilute the high levels of sodium in the blood. Administer diuretics, loop preferably, for clients with poor kidney excretion. The signs and symptoms of hypokalemia are decreased intracellular excitement, paresthesias, decreased excitement of cardiac tissue, flattened T wave, decreased blood pressure, thready, weak pulse, hypoactive bowel sounds, nausea, vomiting, constipation, abdominal distension, possible development of a paralytic ileus. We're going to have muscle weakness, reduced deep tendon reflexes, shallow breathing, orthostatic hypotension, altered mental status, anxiety, lethargy, depression, prolonged PR interval, and the presentation of a prominent U wave. Critically low potassium can lead to disorders de points. Nursing care of hypokalemia includes administering prescribed potassium replacements, never giving potassium via intramuscular or subcutaneous route, as this can lead to necrosis of the tissues. Monitor and maintain adequate urine input. During this time, you're going to want to observe for shallow, ineffective respirations and diminished breath sounds. Monitor cardiac rhythm and intervene promptly as needed. Monitor clients receiving digoxin, as hyperkalemia increases the risk for digoxin toxicity. This is a big one. So you're going to want to monitor anyone taking digoxin. You're probably not going to want to do that concurrently, honestly. So you're going to want to monitor the patient's level of consciousness and maintain client safety. Monitor oxygen saturation levels, which should remain greater than 95%. You want to assess that hand grasp for muscle weakness. Assess deep tendon reflexes. Implement fall precautions due to muscle weakness. And supplement orally and intravenously with potassium. And the main signs and symptoms of hyperkalemia now we're switching over to hyperkalemia from hypo. So going to be too much intracellular excitement, paralysis, a tall peaked T wave, and arrhythmias are most likely going to occur. Other signs and symptoms include a slow irregular pulse, restlessness, hypotension, weakness to the point of ascending flaccid paralysis, premature ventricular contractions, ventricular fibrillation, widened QRS, increased gastrointestinal motility, diarrhea, hyperactive bowel sounds, and oliguria, which is very little urine. And nursing care of hyperkalemia includes monitoring cardiac rhythm and intervening promptly as needed. There's an emphasis here to monitor for cardiac complications. So as you're doing that, you're also monitoring for intake and output, assessing for muscle weakness, preventing falls is a priority here. Observe for GI manifestations such as nausea or intestinal colic. Restrict potassium consumption and discontinue medications containing potassium. Monitor for further manifestations as levels are worked to be brought down through medication. And promote movement of potassium from the ECF to the ICF by administering IV fluids with dextrose and regular insulin. Also, administering sodium bicarbonate can reverse acidosis. The main signs and symptoms of hypomagnesemia are muscle excitation, increased deep tendon reflexes, tachycardia, and possible seizures. Other signs and symptoms include risk for increased blood pressure and dysrhythmias or ECG changes. These include the presence of PVCs, flat or inverted T waves, ST depression, prolonged PR, and widened QRS. Muscle tetany, positive Chvalsteks and Trousers signs, and hypoactive bowel sounds, constipation, abdominal distension, paralytic ileus, possible depressed mood, apathy, and agitation. Nursing care of hypomagnesemia includes correcting the concurrent imbalance of other electrolytes to revert worsening of either condition. So you're going to want to be encouraging foods high in magnesium, such as whole grains and dark green vegetables, also peanuts, peanut oil, those sorts of things. And discontinuation of magnesium-depleting medications, such as loop diuretics and medications that contain phosphorus. You're going to want to administer oral or IV magnesium dependent upon the severity of hypomagnesemia. So have calcium gluconate readily available to reverse hypermagnesemia if you've switched from that narrow reference range, because again, think of magnesium, that's 1.5 to 2.5. So if you've gone, say that you were at a 0.9 MEQ per liter and you've now gone up and you maybe weren't being monitored as closely overnight or something like that, and now you've got a 2.9. So now you're in the hypermagnesemia range, so you're going to want to have calcium gluconate readily available to reverse this. The signs and symptoms, and that's not saying that you want this to happen, this is just a precautionary measure. So the signs and symptoms of hypermagnesemia now are over-relaxed muscles. Now again, magnesium, that has to do with relaxing your muscles. So you're having too much, you're going to have over-relaxed muscles, decreased deep tendon reflexes, and possible respiratory arrest. And these are our main ones with hypermagnesemia. The possible respiratory arrest, this is caused by depression of the diaphragm, and as this is a muscle too, it can become over-relaxed, and then you're just not able to breathe. Nursing care of hypermagnesemia includes monitoring vital signs, noting hypotension and shallow respirations, observing for decreased deep tendon reflexes and changes in levels of consciousness. Medications that contain magnesium are not given to patients with kidney injury or compromised renal function, and patients with kidney injury are cautioned to check with their primary providers before taking over-the-counter medications. Caution is essential when preparing and administering magnesium containing fluids parentally, because available parental magnesium solutions differ in concentration. Lastly, I will answer the question. A nasogastric tube is attached to, that's everything we have right now on electrolyte imbalances. This is a question that I was given, so now I'm going to answer it. So a nasogastric tube is attached to a low intermittent suctioning. The nurse should monitor for which of the following electrolyte imbalances. So the answer to that is hyponatremia. And hyponatremia occurs in this instance due to the nasogastric suctioning any contents out of the stomach. So therefore, any sodium that you have ingested is going to be sucked out, and it's going to leave you with a sodium deficit. And it's attached to all that fluid in your stomach. Wherever water goes, sodium goes. So you suck all that out, all that fluid in the stomach, you're going to be left in a sodium deficit. So that's everything for today. Again, this is a video on fluid and electrolyte imbalances for Nursing 110 Medical Surgical Nursing through the University of Charleston. And thank you for watching.